Welcome everybody for another Global Health Histories seminar. I'm Sanjoy Bhattacharya, Director of the Center for Global Health Histories and Head of the WHO Collaborating Center for Global Health Histories. Today's seminar is on children and research. So I'm delighted today to introduce to all of you my colleague from the University of York, Dr. Amanda Mason-Jones, who's at the Department of Health Sciences, who's very kindly agreed to do the academic presentation, and then Katharine Wright from the Nuffield Council on Biosciences, who is bringing in a very important ethics perspective, but also from our perspective, presenting from the policy world. I've had a look at the presentations, and there are very interesting interconnections between the presentations, which I think we can discuss in detail after the two presentations are over. So Amanda, can I invite you to start with your presentation, and then I'll invite you.
Thanks, Sanjoy. Thank you. So as Sanjoy said, my name's Amanda Mason-Jones, and I'm going to talk to you today about vulnerability and resilience, and particularly in relation to public health research involving young people. For some of you, you may be aware that public health is a branch of medicine that focuses on population health. If you look at the image here, you can see the kind of activities that we might be involved with. So it could be surveillance, monitoring of infectious disease, for example, or outbreaks of disease such as polio or antibiotic-resistant gonorrhea. We also look at patterns of disease and injury, which is a realm of epidemiology, and particularly the social patterning of disease. And clearly communication is a really important part of public health. And we use many different types of research method, which can include quantitative research such as trials, secondary data analyses, and meta-analyses, and qualitative research, so interviews or focus groups. And also we mix up these methodologies. So we clearly focus on risk to populations, and as a public health researcher, this is something I've been working on for the past 25 years, and particularly in relation to young people. If we look at the risks to young people in the UK, and just looking at mortality, so that's death rates, you will see that childhood mortality rate in the UK is higher than many other European countries. And those most at risk are infants, so those under a year of age, and also young people with chronic disease. Injuries remain one of the leading causes of death, and health services don't always deliver the services or the care required. Most importantly, there are marked social inequalities in this death rate, and many of the deaths are preventable. If we then consider the global picture, the patterns are much more marked. For example, the child mortality rate in sub-Saharan Africa is the highest in the world. Infectious disease and injuries are the most frequent cause of death. And health services may not be accessible or affordable, with many people having to pay out of pocket for care. And again, there remain social inequalities within countries as well as between countries. The population group my research has focused on has largely been those known as young people, so those aged 10 to 24 years. However, if you look in any newspaper article, you listen to the news, you often encounter highly negative perceptions of young people. So they're using social media to the detriment of their mental health. And the stories are often framed as part of a crisis, so perhaps a focus on criminal justice. We have this idea that they're a problem in need of a solution. And public health researchers, including myself, have fallen into this trap and have tended to frame our narrative like this. We rarely focus on their development, their role as pioneers of great ideas, and we hardly ever talk about structural inequalities in relation to young people. So here's one example. It's a randomized controlled trial that was conducted in the Western Cape of South Africa. It included around 8,000 to 9,000 young people aged between 14 and 16 years, and reported on a school-based program to reduce intimate partner violence and HIV. So yes, we were focused on risk and we were looking for solutions. Risk and vulnerability go hand in hand. One of the issues with this population was that around 30% were orphaned because of the HIV epidemic. And during the time of the trial, the South African government introduced legislation which insisted that young people needed to have parental permission to be part of such research. But this meant that the voices of children who, without parents and were often head of households, may not be heard or included. So to solve this problem, we worked with neighbourhoods, in neighbourhoods, to secure community consent for the trial to go ahead. And obviously each child who took part also assented to their involvement. This required a great deal of preparatory, participatory, qualitative work before the trial could take place. And the whole trial took over 5 years to complete. In public health research, we also conduct systematic reviews and meta-analyses, which means taking evidence, in this case from a number of randomized controlled trials conducted worldwide, and pulling this together. So all of the data is meta-analysed. And this was a review I led for the Cochrane collaboration. Again, here we were looking at interventions in schools that could reduce the risk of HIV, sexually transmitted infections and pregnancy. And we can see that it received a lot of attention. So this score here shows that it was looked at by a lot of news agencies, and it wasn't always the kind of attention to detail that we as public health researchers might have liked. And maybe it's not surprising because it's not really an easy read. It runs to over 100 pages, this review. So just in summary, so the review included a large number of young people, so over 55,000 young people aged between 14 and 16. And it found that providing a small payment or a school uniform encouraged girls to attend school. And this had the potential to prevent between 3 and 4 in 10 unwanted pregnancies. The review did include a critique of sex education as it was being delivered in the trials, because it was very constrained when you looked in detail at the curricula. So it didn't really educate young people sufficiently well. So the focus of our review was how can we encourage more girls to be at school? And even in the UK, 1 in 5 young people don't complete post-16 education. But only part of that message was picked up. So I clearly failed in my attempt to communicate risk, vulnerability, and solutions to those risks. Around this time, I also sent the Cochrane Review evidence to the Department of Education, and there was a move to develop relationships and sex education in school and to make this compulsory. And then there started to appear this discussion around resilience. But what did they mean by resilience? It seemed to be something about the ability to bounce back and to do well against the odds. It was clearly a popular concept. It sounds great. It originates in engineering and it's been used in economics. When we look at the terms used in searches, Google searches, looking at child resilience, we can see that the geographical spread is very limited to Australia, the United Kingdom, Canada, and the United States. And there have been a number of reports and programs. This one is from Australia, another from Australia, and another. one from the UK, and another. And newspapers also jumped on the resilience bandwagon. We were given instructions on how to build a resilient child. But still, researchers in the field were asking the question, what is resilience? Is it a process? Is it a capacity? Or is it an outcome? It was something about doing well during or after an adverse event. But what was doing well? What did that mean? Are we talking about academic competence, some kind of social competence, or is it something about physical, psychological, or social well-being? In exploring this further, we were told that it was important for children's mental health. It meant that they would be managing stress better, that they would have, it would have potential benefits, both social and economic, to society. It would save the NHS money. And we were told that adversity is not always avoidable. And so it was said that it's generally easier to build resilience than prevent adversity. Frameworks were developed. It was about promoting supportive relationships, focusing on autonomy and responsibility, creating opportunities for personal challenges, and helping people to focus on their emotions. This is a page out of one of those reports. The clear message was that if you fall, you get back up. Children were to be reminded that they were piloting their own plane, that they needed to think healthier thoughts. They needed to distinguish between helpful and unhelpful thoughts, and then learn to use accurate thoughts rather than negative thoughts. So if I've had a bad day at school or at home, I like to try and forget it and refresh my mind. But for me, this was really troubling, and I don't believe this is necessarily healthy thinking. My research was focusing on children who were experiencing risk and vulnerability. But what I was finding was that it was political structures, policies, and systems that were creating this vulnerability. Thinking happy thoughts was not going to solve anything in the long term. Here, my colleague and I reviewed the evidence around the experience of separated young people, also known as unaccompanied minors, who are fleeing to Europe. We used the term on the move, which some of these young people were refugees or asylum seekers. And I was keen to stress that the focus should not be on individuals' grit, but rather on the context and the structural patterning. So yes, the individual is part of that process, but it's part of a much greater whole. And here, looking at serious case reviews of child sexual exploitation in England, it became clear that the failures were more often than not systemic. Again, individual resilience was not going to be enough against the weight of a broken system. So a model that takes in the social ecology is essential. And here you can see the various places within which the failures occurred. So resilience needs to be reoriented. It's a process that needs to be supported by a system that includes these aspects. So this is from Michael Unger at the Resilience Centre in Canada. What has become important and apparent is that children's early years really make a difference. So public health research that looks at early trauma and social and cultural context is really important. And trials that explore what can be done to improve social and emotional health are therefore key. The newest trends in research are looking at interactions between the gene and the environment. And it remains to be seen what light this can shed and how it might improve the lives of young children. So young people need to be involved more and know what alternatives there might be. Communicators need to advance a new narrative that deepens our understanding of young people's need for positive support and enriched environments. And we also need to correct misperceptions of young people and to see that their advancement and well-being is a systemic issue with collective implications. Young people's exposure to structural inequalities fuels disparities in health, wealth, and education. This reframing from an individual to a collective responsibility, I hope, will produce a more favourable climate for reform and culture change, ensuring that young people have the resources they need to thrive. Thank you.
Well, thank you very much, Sanjoy, for the invitation, and thank you very much for the first presentation. I think there's some really interesting cross themes there that we can talk about later. So I'm going to apparently start from a very different angle, I think, and then I think we'll see how some of the themes intersect. What I'd like to do is give you a very quick whistle-stop guide to a 2-year project that the Nuffield Council on Bioethics conducted back in 2013, looking at the ethical approach to children and young people's involvement in clinical research. For those not familiar with us, the Nuffield Council on Bioethics is a UK-based independent body which examines ethical issues raised by new developments in biology and medicine, effectively about looking at ethical advice for policymakers, so what policymakers might need to do to facilitate ethical conduct of research and medical treatment, so not direct guidance to practitioners who clearly have their own sources of ethical conduct. I think a quick word there, particularly in this context, about our UK base. We do primarily work within the UK. This particular project very consciously looked further than the UK, not least because I think a lot of UK funders fund a lot of research in lower income environments with young children, and also because in medical research, a lot of research has to be international in order to get cohorts together where you have very rare conditions. At the same time, we were still very much alert to the fact that we were primarily a UK-based organisation looking at these issues. I think there's a tension there of trying to look broadly while not claiming to be more than we could be. I think that's something we could perhaps discuss later, and I'll come back to. So back in 2013, we started thinking about this challenge of children's involvement in clinical research. I think it's a long-standing ethical problem that was holding back research. And in 2015, we published a very long report, even longer than Amanda's review, with lots of recommendations to policymakers, which we've been following up since. But also, very importantly, I'll just bring with me, we also produced as part of that sort of a magazine version for children, which we produced with children, which is a very interesting exercise from my own perspective. And we also produced an animation which sort of expressed in a sort of 2-minute child's eye view of what being involved in research should feel like as a child if done well. So we're very aware of, in thinking about this issue, we had to think about our audiences and how we made our thinking available too. As we normally do as a project-based organisation, when we identify an issue we think there's something ethically challenging that we could make a contribution to, we set up an interdisciplinary and expert working group. So that normally involves academics and practitioners across a range of fields. And then that group itself is then in charge of a series of roundtable meetings, online consultations, literature reviews, and so on to bring in a wide cohort of stakeholders. But I think a really distinctive point about this particular project was the very inclusive way we sought to get input from children and young people and from parents and also from professionals across 4 continents. I think we're aware that we were primarily a UK group. We had 2 members from Kenya, but their connections actually in Southeast Asia, elsewhere in Africa, and then across Latin America did enable us to hear, at least to a degree, from those with very different working experiences and working with children with very different lives. And just a quick note that all the illustrations in my talk are all from materials produced by children and with children as part of this project. So what do we set out to do? The question we asked ourselves was, how can we ethically do research with children and young people to ensure that they receive evidence-based healthcare? And initially, I think we saw this as a fairly straightforward dilemma, on the one hand, on the other. So I think we have a natural instinct to protect children from research. On the other hand, we also expect our children to have access to evidence-based healthcare. And my son at the time, I think, was 8 when I started this project. I'd have fascinating conversations at the school gate with parents who were daft enough to ask me what I was working on. And the first reaction will be, well, surely you can't experiment on children. The number of times I was asked that was striking. And then when you say, but when you go to the GP, wouldn't you sort of quite like to know there's some evidence base for the medicine that's being prescribed rather than off-label because we haven't been able to research with children? Or if you go to the hospital, you have recommendations as to what secondary care they might have. Surely we want an evidence base for that. I think that illustrated some of these tensions. And I think very early on, it became clear to us that this framing of on the one hand, on the other, actually missed out a critical third factor, which is the role of children, young people and parents themselves in this whole picture. And I think importantly, not just about making decisions about research involvement, but also about wider questions about what research is getting done and why and where. And in looking at this sort of trilemma, this sort of three-part question rather than two-part question, I think slightly unexpectedly we found ourselves exploring and challenging some of the assumptions about children and young people who ethically have always been considered a vulnerable population, a vulnerable group. And I'm to come back to this idea of a whole group being vulnerable and what that's meant in ethics as we go through. So this sense of where do children and young people themselves sit in this, I think was very influential in the methodology that we developed as part of this project, and that in turn influenced the ethical approach that we took. So we started off with a standing advisory group, a stakeholder group of young people and parents. Initially we drew heavily on the Royal College of Paediatrics and Child Health group, which gave us a way in. It was a group that people came and left from partway through the process. I think we accepted there wasn't a group who would stay with us for 2 years. That was a large chunk of time in teenage children's lives. So people would dip in and dip out. But the idea was to be able to hear from children, different children's voices throughout the project. Those young people helped us devise an online survey. I have to say my first draft of it was very thoroughly re-edited or rewritten. And that drew in a lot of young people involved in the National Institute of Health Research's Young People's Advisory Groups, or YPAGs. So there are, I think, around 6 of these groups in the UK who meet, I think, mainly monthly on a Saturday, and they advise researchers about their research. So they're a very inspiring group of young people. And interestingly, I think they're perceived as being perhaps young people who are going to go into medicine. Actually, there's a really good cross-section of teenagers who get involved in them after work experience in hospitals and that kind of thing. They gave us some really good input through those online surveys. But we were very aware that they were a particular subgroup of young people who were interested in research precisely because they're involved in these groups. And we were very keen to hear from a much wider range of children and young people, because I think one of the features of research for children is that the opportunity, the invitation to take part in research may come out of the blue after a sudden diagnosis, in some cases after a very extreme diagnosis, such as a cancer diagnosis. And so actually thinking about what might a child coming completely afresh to these issues, how they might address those questions, was really important. And we teamed up with some academics in Sussex and London to do what we called our Youth Rec Research Ethics Committee project in Brighton schools. So we produced a mock protocol about childhood asthma with a consultant from Brighton and a child with asthma in Brighton, a fabulous family. We had a little film of a mock Research Ethics Committee critiquing this review. And then we went into these schools, primary, secondary and sixth form, and children discussed what they thought of the study. Then they watched the film of the adults' comments, and they didn't always agree with how the adults regarded the ethical questions, and they had their own considerations, and that's all been filmed on our website. It's really a lovely resource, particularly the primary school children, who of all the groups were faster to actually grasp the study methodology and what was involved than some of the older ones and even some of the adults, to be frank. So that was absolutely fascinating. And then going wider again, we had 2 members from the Kenyan Medical Research Institute on the Kenyan coast in Kilifi as part of our group. And that particular centre has an extraordinarily developed an interesting community, sort of a long-standing community engagement project with their local community representatives influencing the research that's done, and also into the schools. So we were able to feed into that and get focus group discussions both with the Kemri community representatives as parents and young people in the schools. And we were very conscious that was what it was, the views of a handful of people in particular schools in a particular area in Kenya. It's not African input, it's not low-income country input, but it gave us a further triangulation, if you like, of the views of children and parents, often in very different situations, and some striking similarities actually as to some of the reactions that came back, and clearly some differences. So where did all this take us? I think most of all it helped us with what we call the ethos. The first chapter of our report is about the ethos of this report, what our framing assumptions are in writing about children and research. And most of all, that was the perhaps blindingly obvious comment that children aren't passive, that even very young children can and do express wishes about how they want to live their lives. They want to have a say. And obviously that say may not necessarily be followed, but it has to be heard, it has to be engaged with. And importantly, they do that as part of their families, and that's the family they happen to have, rather than the ideal family perhaps we would sometimes like them to have. And I think that led to a strong focus on respecting children as people, regardless of whether or not they have decision-making capacity. And I said that, that seems, I say it now 5 years on, that seems a blindingly obvious insight. I think it's fascinating how even research regulation in health is different from children's healthcare, which has been very much family-focused for a long time, how research regulation has still focused on protection, on not doing things, on looking at proxy decision makers, and hasn't looked at how children themselves can engage. And I think one of the most important things that came out of this project for me was a change of one preposition, which is about thinking not about research on children, but research with children, and how we frame it as being as children being part of this conversation. So that moves me nicely on to this question of vulnerability, and how I think within ethics, the way that the language of vulnerability has sometimes stood in the way of good research. The general assumption, I think, in the ethics of research with children and young people is A, they are all vulnerable, so they are regarded as a vulnerable group. And basically, if in doubt, it's safer not to do the research. And certainly we had anecdotal accounts of people filling in their ethics forms as part of a research protocol and explaining they're excluding children from this study because they're a vulnerable group. Full stop, no other comments, despite the fact that it might be something that affects children's lives or could be equally applicable to children. I think one of the real challenges with that approach, this overprotective approach, is that it's not necessarily ethically neutral to say no to research that could lead to better outcomes for children and young people. It's not necessarily the safer option. It can be a cause for harm in that we continue to give children care without a decent evidence base. And at the time we were writing this, it's about 90% of medications in neonatal wards were given without a clear evidence base, and I think 60% outside the neonatal sector. So it's still incredibly high. And even though there's some evidence, it's lower levels of evidence, things might work, that wouldn't be acceptable in adult healthcare, so how can it be acceptable in these more vulnerable populations? And secondly, I think one of the very strong comments from the children and young people we engaged with, I think over 200, was where they wanted to have the opportunity to be asked. They might say no, as any of us might say no, but they wanted to have the opportunity to be asked, to be respected in that way. Of course, it's really important to keep in view that children can be very vulnerable in research, as indeed, of course, can any adult. And I think in this case, it's important to think of the vulnerability being in the situation and not necessarily in the person themselves. I think this speaks to some of the things Amanda was talking about systemic reasons why people might need to be demonstrating resilience. So to take a quote from one of our consultation respondents, the term vulnerable can't be used in isolation. We are always vulnerable to something specific, and the things that we are vulnerable to change over time. And I would add one really important further point to that, which is that there's quite often things we can do about that. So I was very struck at the start of this project, I think it's a 2011 report from one of our sort of sister ethics committees in another country, listing all the reasons why children were vulnerable as a group for clinical research. And it said children are vulnerable because research takes place in alien surroundings, they don't know what's going on, and they're separated from their parents. To which the next question might be, well, can we make the environments less alien? Can we make sure they do know what's going on? And can we make sure we do it with their parents? All these things, in some cases it may not be possible to change those things, but the starting point should be thinking about how we do it, rather than just listing that as a vulnerability and saying, let's not go ahead. I think one of the conclusions of this report with respect to vulnerability is, can we think about it not as a stop sign, not as a don't go there, but more positively as an alert, as a prompt to think about what can we do to actually challenge the potential vulnerabilities in this situation. So we suggest that researchers should think about 3 specific questions in this context of children as a vulnerable population or potentially vulnerable population. First, what ethical challenges does this particular project raise? And we're talking about research from newborns, in our case, up to 18, but Amanda was talking about this idea of young people going up to 24, and obviously the issues are very different once you're recognised as an adult, but still have certain developmental challenges sometimes. What can I do about those potential vulnerabilities? And really importantly, who can help with that? And that brings me, I think, back full circle to my first point. One of our core recommendations is about researchers working in partnership with children and young people and their parents. And that's not only, obviously, in terms of particular children when invited to take part in research, how they make that decision, but actually the much bigger picture stuff in how we prioritise research in the first place. You know, why are certain medications, certain illnesses, certain issues prioritised for research and not others? Who is setting those priorities? Are the experiences of children's lives actually influencing those? I think particularly importantly in the design of studies and the extent to which they take account of children's lives, and possibly even in review of research, at least through reviewers being alert to the fact or asking questions about whether young people have been involved in earlier stages. And certainly speaking to the National Institute for Health Research Young People's Groups, they described, and I heard pharmaceutical companies reps talking about having gone to these groups and having had their proposals well and truly scribbled all over, you know, with questions like, well, you know, really, three blood tests in 3 days, is that really reasonable? Other ways around that? If you do that every Thursday, I miss maths every week. You know, do you have to think about some flexibility? Things that seem very obvious to children and parents in terms of what children worry about, or what, or just the issues in one's lives that matter, or the school day. But also thinking in terms of whether a more specialist needs, for example, the groups specialising in Duchenne's muscular dystrophy or asthma, or many other specialist groups who can really offer that kind of detailed advice as well as the more general. I think importantly, we had a certain challenge from a certain sector of researcher that effectively the only ethical question was whether the information was clear for parents and children to say yes to. So the idea of consent in research as being almost a contract, as long as you know what you're doing, it's okay. And we pushed back very strongly on that. We said that research had to be something we called a fair offer. It had to be something it was fair to ask people to do. And that partnership with children and parents and young people could help one decide if this particular study for this particular cohort of people will be a fair thing to ask them to do. But you still have responsibilities yourself as a researcher. The fact that somebody in a desperate situation might say yes doesn't make it good enough. You have to be sure that what you're doing has had all the right checks and balances. So responsibilities rest with the researchers, with reviewers, ultimately with funders, but working in partnership to understand the experiences. So I think it's a question of accepting the partnership but not putting the burden. I think that's quite an important balance. We can come back to that. And then that can sound like a big ask, but it is happening. And the UK groups, I think, have been going for a few years when we started, have clearly been trailblazers. At the time, I think the time we published, there were 1 or 2 groups starting in the US, and that's now developed. A couple of groups in Europe, I think, have now a full network. I know our Kenyan colleagues have been working to set up a young people's group where we were in Kenya. And so I put it there in brackets because I think there may be others I don't know, but certainly I was fortunate enough to present our youth rec films in a meeting in Malawi back in 2014. And the director of the Children's Hospital in Siem Reap happened to be there, and she has since set up a group who advise both about the hospital more generally and about research. So I think that's a really fascinating development, because I think one issue we've discussed since in international meetings on this project is to what extent are we thinking about a very European, American approach to robust children who expect to have their voices heard. How does that play out in more hierarchical societies where children are expected to be more respectful? And certainly, the Cambodian example apparently has been very successful, partly by framing it in terms of educational opportunity for children to have this chance to comment. But it apparently has been very influential. So I think there'll be different ways this kind of influence can be heard in different contexts. And it has obviously to work with the grain of the culture and where it sits. But we've certainly heard of examples of it working in very, very, very different contexts, in Latin America too, in Peru. So thank you very much. I'll leave that there, and I look forward to the discussion.
Thank you so much for 2 wonderful presentations, research intensive, which makes it all the more fascinating, and one about methods, which I've just served on a working group, so there's so much more work that all of you help us with, the working group members. I mean, I can only imagine the complexity of some of the work you described.
I think we learned a lot from that project, which perhaps moved on into ours with
for this
health.
one.
Yes.
Questions from the floor first, comments, questions, or apparently we might even get online questions. Suranga?
I have really two questions here. The first one is, now how do you apply some other methods for the really empowerment of the vulnerable population, especially teenagers, in terms of handling the situation, where I have some experience where we can give sort of a life skill training to teenagers, those who are more vulnerable for, in terms of sort of the early pregnancy or even the addiction, due to even the peer pressure. So in lower resource settings, any sort of requirement in terms of the empowering children with the knowledge, or even the help making them in give them a knowledge about the managing the situations. That is my first question. The second one is, now the online surveys are highly popular. So in terms of getting consent from the online survey, especially the teenagers or even young adults, how would be the validity of that consent? So,
Do you want to start with the first question?
Yeah. So it's a really interesting question. It's interesting when you talk to young people, they often have the knowledge. It's not something they need necessarily. Obviously, education is really helpful. But I think what we found in the research we've done is that you need to provide the environment and the structure to enable them to utilize that knowledge. So I think in terms of the kind of things we did in the project in South Africa, we introduced school nurses into the school. There was no health service in the school. So we introduced that kind of structural change so that young people had the ability to seek care and seek advice when they needed to. So I think you need to combine the knowledge and the information with some kind of support service, and I think that's really, really important. Does that answer your question?
yes, yeah, partly is answered. My main question is there any position we can make any sort of a program to empower children, not with that knowledge, even the skills to develop, to manage the difficult situations in terms of the peer pressure in going for smoking or there's some addiction. They need to develop sort of skills to reject that type of pressure.
Yeah, I think it depends what particular issue you're talking about. So I think there have been some good peer programs, peer education programs around smoking that have been very effective. But you can't necessarily translate those to, say, sexual and reproductive health, because the context and the challenges are very different. And I think that is what often we have done, health educators, health promoters. We've tried to use one method of, say, peer education, that's going to work, and we've transferred it to different contexts. But it shows a kind of lack of understanding of what goes on in young people's lives. So I think that's where the participation comes in, that's where you really need to work with young people and say, what are your challenges? How can we support you, instead of just kind of transplanting programs from one context to another.
I'll try and answer your question about consent online. I mean, I think that's a fascinating question, and much more generally than either young people or low-income settings. I mean, I was struck just coming up on the train this morning when I was signing up for the Wi-Fi. Probably like everyone else in this room, I read the terms and conditions without remotely looking at them and pressed yes because I wanted to get onto the Wi-Fi. So I tried to open the document. So I think we are all sort of guilty of that. And I think that picks up one of my points about the fact that it's not just about consent. Actually, it's about whether it's a fair process in the first place. And what kind of regulation is there to make sure that there aren't ridiculous bits of those terms and conditions that I've just clicked yes to without checking. I think more broadly, and again, I think this is a very wide issue across health ethics and treatment as well as research or other engagement, is around how we think about consent at all. I think consent has become, I'm to invent a word, very regulatorily-alized. It's become something where we focus on regulation and about how do we give someone an awful lot of information and then ask them to sign a bit of paper or online to tick a box. And I think there are all sorts of ethical reasons why consent is important. And a lot of that's around respect, it's around power, it's about making sure this is genuinely your decision and nobody's tricking you into anything. And actually, on the whole, giving people lots of information or asking them to sign a paper doesn't actually do any of those things. It's there supposedly as evidence it's been done, but it in practice may not do it at all. I don't need 20 pages of documentation when I'm taking a new medication, for example. I have a trust-based conversation with a clinician and then decide to take it. So I think it's unpacking some of those other bits, again back to the idea of the sort of structural questions. So we're thinking specifically of research online, so how people have consented to that research. So I think there are two things I would say there. One is about having a very clear statement about what the research is about and what the risks or benefits might be. So not the 20-page equivalent information sheet, but the half paragraph that any of us would read. And the other, I think, is this idea of a fair offer, having reasonable reassurance that what you're asking them to do is actually a fair thing to do. You're not tricking them in any way. Because then whether somebody's read all that stuff or not, or bothered to click through terms and conditions, becomes less important, because what you're doing is fair in the first place. So I think a lot of these things feel quite circular. If you're confident in what you're asking, how you're asking it, has it been piloted? Is it actually responding to the needs of real young people? Is it asking questions in ways that aren't going to be distressing? All the other bits of due diligence you've done as part of the research development. Then consent is still important, but it's not the be-all and end-all. It's one bit of a sort of an ethics ecosystem. Two fabulously difficult questions.
From years of government training. I mean, if I could, so Amanda, I was fascinated by that paper about child refugees, because it's something that's topical, and what's happening currently is deeply upsetting to some, at least in this country, about the changes in law about young people not now having the right to be reunited with family. Now, from an ethical point of view, when you did this research, what was the biggest ethical challenge that you faced during this research? And secondly, I have a question about middlemen and women. What role do they play? Especially when you're working with refugees and asylum seekers who often do not have access to English. So I'm thinking about the language issue here. So
yeah.
Perhaps.
So the reason we did that work was because it was such a topical issue.
Yeah.
And if you can imagine trying to get consent to do something through an ethics committee, that would be really challenging. So what we did was we actually used reports that were already available in the public domain.
Mm-hmm.
So we didn't speak directly to young people. What we did was we pulled together all of the contemporaneous reports that were around, and we kind of meta-analysed that in a qualitative way.
Okay.
So that's how we did that. And it felt important to do that, first of all, because the voices of those young people were not going to be heard. And also we wanted to get that message out quickly. And if you were sort of going to go through the whole research process, it would take a long time. So that's how we did that work. And you talk about the middlemen and women.
But that's irrelevant, because if you didn't interview and talk to these people.
Yeah, but it did come out. So there was a lot about language barriers for young people. So obviously there are all of the legal implications. That's why we called them young people on the move. So separated young people on the move, because refugee and asylum seeker are particular legal definitions.
Yeah.
And there are many young people who are on the move who don't have those official that official definition. So, so they're even more at risk and more vulnerable in those situations. And a lot of the work that had been done by non-governmental organisations shows that the language barriers and the political difficulties were really the main issues for them. Yeah.
So did this also include the trafficked children?
Yes.
It
Yeah.
did.
Yeah.
So did you use that as another category?
Yeah, it was part of the bigger category of young people who are moving away, from danger, and often moving into new dangers. Yeah.
Did you find differences between those groups because of the legal classification of what rights you had or what services you might get as an asylum seeker or as an accepted refugee or as simply someone on the move?
Yeah, so I guess the data weren't there in detail enough to be able to do that comparison.
Yeah.
But the sense is that if you have a more legal definition, there are certainly the data is more available.
Yeah.
So you would have that information. So there was information about young people who'd arrived and they'd had really good welcome. They'd had services that were available, and their long-term outcomes were really good.
Mm.
Whereas if you're trying to dodge, border control, then your outcomes are much more challenging. So.
Yeah, and so my question comes from the perspective of people who work on India and South Asia. Because it's not just an Indian problem; it's a South Asian problem about child labour, and just as India's Indian government would say, we don't have refugees, we have internally displaced people.
Yeah, yeah.
There is also, childhood displacement within countries like India, where basically economic and sometimes trafficked children are forced to go into sort of domestic, very violent, very abusive domestic servitude. So it would be fascinating using your methods, but looking at a context like that, where people are moving, but moving within their country, but these are countries of almost subcontinental, continental proportions. And, but then language comes in, because a lot of that writing is not necessarily in English. The gentleman who, Satyarthi, right? The gentleman who won the Nobel Prize, a lot of his writing is actually in Hindi and not in English. So that then raises ethical issues about how we access voices other than in the English language. So is this something that came up when you did your...
To a certain extent in this project, we were incredibly fortunate in that the working group members we had from Kenya, their colleagues who, I think the focus groups were conducted either in English or one of the language, or I think it might even vary between the schools. By some sort of quite chance, sort of serendipitous connections, our consultation document was just translated for us into Spanish by someone who's contacted us from Lima saying, I've come across this, is wonderful, do you mind if I do this? And we said, please, that'd be wonderful. And she actually facilitated quite a lot of response from Latin America. Right. And in fact, we then worked with partners in Latin America, the American University of Beirut, and is it Shanghai? We had completely chance contact from a hospital in China, I think from Shanghai, to translate the animation. So the voiceover is actually in Arabic, Chinese, and Spanish as well. Wow. So I think it was an interesting tension in that project, because we did devise it initially as a UK-based project, then we realised we really wanted to be alert, as it were, beyond the boundaries of the UK, while being aware that we didn't have the money to make it a genuinely international project. So I think actually through lots of connections it managed to have lots of international elements. But I think we still had to recognise that most of the thinking had been UK-based and not make excessive claims for that. A year after we published, actually, we had a roundtable meeting with, I think, 20-25 people from 14 different countries, from really quite widely dispersed, debating what this might mean in different contexts and in, obviously, in very different cultures. And again, lots of wonderful examples, actually, of participatory work with children in different contexts. So I think it has had quite a wide spread. I think that contrasts with the work that you've been very kindly doing with us more recently in the Nuffield Council, Sanjoy's been involved in a working group with us on how we conduct research ethically in global health emergencies. So both outbreaks like Ebola, but also after the Indian Ocean tsunami, after earthquakes, in conflicts and displacement of people and so on. And that was very consciously set up more, with a bigger budget in order to bring in a much wider group of working group members and very consciously having meetings around the world. So I think there we can feel that we have had a genuinely international input. I think with this project we did our best as we went along, but we shouldn't make claims in terms of the methodology to be more than UK plus as opposed to genuinely global. And we are we're aware that that's the limitation.
Every one of these reports is a step to learning.
Exactly.
So that's how
I think we have to be careful not to say this works beautifully in the UK.
Yes,
therefore,
absolutely.
I think we're very conscious of
I
that.
wish other organizations said the same as well. It's rare. But thank you for saying that.
Thank you both very much. Is this on? Okay. I was curious to know about, Katharine, your work involving kids. I love the idea, having children involved with you in the research. I've also sort of seen what government grants can look like, and trying to understand the practicalities of if you were to, if this were to become standard, is there the concern that that might then add on more and more layers of regulation, which is sort of the opposite of what you want in the first place?
And I think there's always that tension, isn't there, that things get turned into a process that then becomes more burden and doesn't necessarily add to the sum of the parts. We are a policy-based organisation, so I say we very much make recommendations to policymakers. So part of this report was about making recommendations to funders that they should be allowing the costs of doing this, and in particular that the young people's groups as part of the NIHR should get properly funded. So for example, when pharma are going to them and asking for their advice, that should be funded. And I think interestingly, actually, I think the pharmaceutical companies we spoke to were actually very comfortable with that. There's more of a challenge of whether the people running the groups felt able to take the money. So how you find a system where the money is seen to be clean, as it were. People are paying their way, but they don't appear to be some buying privilege. I think it's a relatively new area in terms of actually having a decent evidence base for how much difference it makes empirically as opposed to ethically. So I think you can make a very clear ethical argument that this is how you deal with some of your ethical concerns about exploiting children. It's about working respectfully with them. So I think you can make a justification on those grounds. The extent to which it makes a difference in the process of research is obviously an empirical question, and I think there's been a bit of work on that, but not enough. Anecdotally, I've been to meetings organised by NIHR where organisers of major pharmaceutical studies have said, I went to one of these groups, they talked to me really quite brusquely about ideas in my protocol, I amended it, and it was really easy to recruit, and compared that with previous projects where you have a study which a child looks at or a parent looks at and thinks, well, how can I do that? I've got 3 children to get to different places, you expected me to be in this place every Thursday at 3 o'clock in the afternoon, I've got a job, how do I do it? Things that actually aren't rocket science, but if people aren't used to working with children and don't have that sense of how on earth we juggle parenthood and school life and work. So the anecdotal advice seems to be that if you go through this process, and it can be as simple as going to asking one of these groups to review your protocol, or looking at all the materials that they produce in terms of they offer advice on how to write things in a child-friendly way and so on, or they rewrite information sheets for you. In a sense, at the moment, it's a gift that the NIHR is making available. Obviously, the more people who started doing it, that model will become less viable. So I think that's where you'd have to then look at actually having both a development of the generalist groups, and then, I think I tried to rush a bit at the end, the idea that obviously for some kinds of studies, it's much more important to go to specialist groups. If you're talking about how a child might react to a non-interventional study, that's a pretty general question. If you're trying to understand the experiences of a child with asthma and what you're actually asking of them extra in this particular study, then going to the National Asthma Campaign and their parent and children groups is obviously a more appropriate way. So there are lots of different models. But I think what you describe is the tension in so many well-meaning ethical endeavours, I think. And it's one of the challenges of the whole idea of Assitant, which is about trying to involve children appropriately in the process, but has ended up in many cases of just being, here's a form, will you draw a smiley face? And that is not necessarily the most appropriate way of making a seriously ill child feel that she's being listened to.
I mean, from your own experience of working with NGO sectors, I mean, did you relate to the themes that were being raised today?
Yeah. I briefly worked with a group in Boston who, I don't know if you know of the Spark Center.
Yes.
They work closely with HIV affected kids and do phenomenal work. And so their work came to mind quite a lot. But yes, and then I've also had some experience going through dealing with government grants, and I was just imagining what it would look like if in those grants, they were saying, all right, you can involve children but only to this extent, and just imagining how it could possibly snowball. But as you've described, if it's a reference group that then strengthens your grant applications, I think that makes a lot of sense, yeah.
No, I think it's generally a growing area of interest, I think, across research, not necessarily just in children. And indeed, in the work we've been talking about in global health emergencies, a lot of being, in this particular extreme scenario is how do you actually make sure that research is really based on the needs of people who are actually experiencing that emergency, and how it deals with their most urgent needs and what either you think is their most urgent need or just happens to be a handy place for your study. And I think naively I sort of thought that didn't happen, and then discovered quite how much it did. But I think so there is a move much more broadly about how patient and public involvement in research should be influencing choice of questions and choice of study design. So I think it's something that the world as a whole is moving towards slowly, but it does feel quite slow. And policymakers have to take it on the chin and have to provide the funding and the funders.
I mean, I must say the report on global health emergencies is going to be, the announcement is going to be has been translated into 5 languages.
Currently being translated, yeah.
So we launched on the 28th of January, so watch this space.
Yeah.
That's 2 years of work.
2 years of work, yes.
Look out for our website for that one. That's 28th of January.
Any more comments? Yeah. Okay.
Thank you. I guess my question is a little bit more broad in regards to sort of challenges of research. I was thinking, Amanda, you mentioned that the interpretation of the research in schools with resilience and the use of that term I'm quite familiar with, having been in schools for the last few years, and that idea of resilience for an individual being pretty much central to what we were being told we should be teaching the kids. And I was just wondering how you manage the public response to the research and to try and communicate the messages you're actually trying to draw from that, rather than the way that the systems decide to interpret them.
Well, you can see I haven't done that very well. So
No.
I don't think I'm a natural. I mean, I think that is something that we probably don't get trained in enough, actually. So we're, good at sort of doing the research and taking years to do it, but actually communicating that, and in a way that is precisely the way that you want it to be communicated, is quite challenging. So I'm not an expert in doing that. Maybe you've got some ideas about how.
No, I'm not so sure. I think there's an awful lot of red tape surrounding schools that and the bureaucracy of the setup actually causes an awful lot of issues with regards to this. Partly the reason that I've left the profession from that perspective, actually.
Really, yeah. It just bothers me, this idea that children individually need to have grit and they need to like cope with this stuff. It just seemed like we were missing something, and I don't know how you challenge that. I think it's something that we need to think about, and I think it's really showing my kind of thinking at the moment. I think there's a lot more work that could be done. So I haven't got the answers just yet. Sorry.
Thank you.
I think more generally that illustrates a sort of the research into policy and practice sort of problem, doesn't it? How we do get what can be really clear research in the academic sector, how we both communicate it, and how it's presented in the Daily Mail is not going to be in our control, but how it's communicated to policymakers, and then whether policymakers want to listen, how it fits into sort of current political thinking, or how you find particular ways of slotting it into things that are happening. I mean, I think that is a missing piece in many cases, and it's something that, again, on the whole, when people are funding research, they don't necessarily fund that translational time.
Yeah. I often think about the sort of road traffic injury research as well. So a lot of, if you look globally, a major issue in public health. But educating people about how to cross roads is not really the solution. And some people, some countries have taken that on board. So in Sweden particularly, they look at road layout, they look at particular spots where accidents occur, and they can see that there's a bigger picture here. So I think it's, in terms of being a health researcher and from a health background, you can see that public health is bigger than health. So it includes education, it includes teachers and schools, policymakers, physical environment. So I guess it requires that multidisciplinary, you know, all in it together kind of approach, which I think that's where we really always struggle. So that's a long ongoing issue, I think.
Yeah. And I was struck this morning actually on the news that someone from someone quite senior in the NHS was making the link between gambling regulation and mental health services and saying, yes, we're providing more addiction services for really quite young people, but actually, you know, at a regulatory level, we need to be dealing with gambling, because what's the point having a failure of regulation that then has its knock-on effects to the NHS? I thought that's a really interesting example of actually hearing in public those kind of cross-disciplinary conversations being had.
Yeah, yeah. And in terms of, you know, alcohol limits and regulations, you know, they're the things that affect public health, you know, so not really individual behaviour. Yeah.
Questions, comments? Number
one clarification. I was just wondering, this category children itself. I mean, I didn't sort of understand, because one of the challenges, for example, in India with this category, and I've seen it often, is with the young girls. I mean, legally the age is 18 for legally permissible age for girls. It is 18. So girl under 18 cannot legally be married off. For the boy it is 20, for a man it is 21. It's a little strange, and also it seems that people are just waiting for girls to turn 18 at times. You know, so I mean this category, and then and also it's a pretty broad category. What are your thoughts about vulnerability? Because I mean I'm quite confused as to how do we deal with this category for different issues like alcoholism or for sexual and reproductive health, because we do know that teenagers are active much earlier than 18 or 16. Are they really children? And this came up even more now with this case of Jyoti Singh Pandey being the rape victim. One of the person who raped her, violently raped her, was under 18. And he was sent to the juvenile court. I mean, and that was one of the most gruesome rapes in this country. I mean, how do you deal with these categories? I was just confused. Thank you.
That's a fabulous question, and I think it's one of the things that we debated a lot at the start of our project. What on earth do we mean by children and young people? And I think, as you illustrate, you can use different cut-offs or categories for different purposes. So often it's apparently about empowerment, being allowed to do things for yourself. What you're describing actually is almost being protected and not being married off too soon by having a cutting-off point, or by perhaps having a more benign court system at certain ages. And one of the things we resisted doing was putting firm ages, just because children are so different and cultures are so different. So what we did in a very general way is we actually described 3 sort of categories of experience of childhood, and emphasised those, you know, they don't have clear age boundaries, and people may be in, the same child might be in different ones for different reasons. So we thought about the child who could not make any decisions at all for themselves. So that could be a child of any age who's unconscious, so always so severely ill that they can't be engaged in any kind of discussion about their healthcare, where parents would take a big role. In practical terms of decision making, that would also be young babies. Though we did have strong input that even very young babies can indicate how they feel that yes, but they're not saying yes or no to research. So then we had a category 2 of the child who clearly didn't have decision making capacity but wanted to have a say. And that's really as soon as the child is becoming vocal. Certainly, and most 5, 6, 7, 8-year-old children would have some sense of whether they want to do this or didn't want to do this. And as I said in my talk, that doesn't make that definitive, but it's something that has to be heard, and I think we all know that as parents. And then we had a third category of children who are not legally regarded by their jurisdiction, and obviously that will vary all around the world, as having decision-making capacity, but actually for this particular decision, do have the capacity to make that decision, and therefore ethically should be asked for consent rather than assent. So we said in practical terms, if you're asking, for example, a 15-year-old who is perfectly able, very interested, has no questions about whether they can make their own decision to take part in a study, the law of that country might say that their parents should consent. We should also say that child should also be asked to consent as well, because there's no reason why two people can't indicate consent. And then we also looked at the very sticky question, I think you sort of touched on, about what happens when you talk about adolescents who do have a decision-making capacity to take part in particularly a non-interventional study, but where the law doesn't permit them to do so, but yet where there may not be a parent around to say yes, or in some cases for drug-taking, sexual behaviour, if the parents are involved, the research will be pretty meaningless because you won't get the accurate answers anyway, or the parent won't permit it. And we did discuss the examples of where ethics committees should be able to approve that kind of study on the basis of, for example, community consent, but obviously only if the law of their country permits that. And in many countries it may be silent, so it's possible for the ethics committee to do it. Obviously the ethics committee can't approve something that's explicitly not allowed. So I think that'll be a different issue country by country. But I think, as you pointed out, the difference between a 2-week-old baby or a neonate and a 17-and-a-half-year-old, you are talking about completely different populations, which is why the whole idea of them all being a vulnerable group in classic ethics terms is meaningless, because they're vulnerable in such different ways, and all of us in this room are vulnerable in different ways as well. So there's a classification of vulnerable group can often miss out the actual vulnerabilities as well as being overprotective in others. But I mean, I was very struck, I think, again, towards the end of this project, I came across, I think it's UN classifications going up to 25 of young people. And obviously that brings a further tension if you're looking at a cohort of people, some of whom will be not be regarded as minors in their country's jurisdiction, and some of whom are. That's even a more complicated grouping, isn't it? And again, it means looking at each case by case, the extent to which they can either legally consent for themselves, but importantly and separately, I think, ethically make those decisions for themselves.
Yeah, and I think so. The WHO definition, I've been working mainly around this adolescent group, so the WHO definition is 10 to 19. But historically, I think adolescence has been seen sort of 10 to 24, so because it's been seen as a developmental kind of stage. So we're not necessarily looking at legal cut-offs, because obviously they vary from country to country. So I think I really like the idea of more this developmental view of and it's a progression as well across the. Yeah.
So I think, just before we published, one of our working group members came up this week with a lovely analogy of saying, we really don't need to focus at what point at midnight the child sort of stops being 17 and becomes 18. You are that different 1 second each side of a midnight. It is a development process. Because we heard, I think both in research and treatment, of parents of, say, 17-year-olds actually being excluded by clinicians from the room, even if the child wanted them there. But any of us might want a supporting voice. And particularly a 16, 17, 8-year-old is quite often, depending on relationships, actually quite keen to have parents supporting them, as long as they're feeling respect in their own decision making, and forcing them into being isolated in that decision making. I think is as problematic as excluding the child in the first place when they're younger. So I think this focus on how people operate in families and who they want, who they find supportive and want there, is a really important part of the process.
Does it answer your question, or do you want to come in again?
It's a lovely wide question. You can talk afterwards.
Use the mic. Because
Sorry, it also comes from it also comes from what you see on the ground, isn't it? I mean, this whole thing really came up with the Jyoti Singh Pandey violent rape, because nobody was really. New Delhi. Yeah, this was in New Delhi, and the verdict is that the others are, it's getting delayed currently. Today's latest is that those people are not being hung, though that's the capital punishment that has been advocated, and it has a lot of public support because of the violent nature of the crime and to act as a deterrent. But this whole question of, nobody was really very happy with that man being treated as a child, and it's just these questions are really difficult. Also, since I teach in a primarily undergraduate teaching institution in India, we know that many of our undergraduate students are married off in the 3rd year of their college. So and you know why. The parents were probably just waiting for them to turn 19 or 18. and they say very frankly, if we were in the villages, it would have happened even before we turned 18 or 19, because it wouldn't be under the scanner. So, but many of these students are really at a very level. I mean, I don't think they should be getting married at that age. They come across as really very young, and your categories of developmental stages, and in any case, in their case also, they're not the ones who are making the decision. I mean, this whole question of making decisions and consent, I think we need to look at them very differently, where, you know, in certain environments, you know, committing your own sexual and reproductive capacities to another person is not consented by yourself. It's decided by other people. So I was just, I mean, it's quite difficult to answer these questions. And I was quite struck that the UN thinks 10 to 19 is adolescent. I mean, this is also quite strange, because I was under the impression 10 to 15 is adolescent, 10 to 16 is adolescent. And this is, thank you very much for this. Yeah, these were just thoughts, not really properly framed questions. Thank you.
Well, that's the aim of these seminars, to provoke thought, and clearly thoughts have been provoked. So if there are no more questions, no more comments, I'd like to thank our speakers for two wonderfully thought-provoking presentations. Thank you for being here today. I'd like to thank Namrata Ganeri for organizing this event, and Arnab for all his help. And we can look forward to a report from Alex in due course about the event, which will be up on our website, up in lights. And maybe Lou can translate it into Chinese, you know, and distribute it. You know, Chinese social media networks, outreach, international outreach. I'd like to thank the Commonwealth Scholarship Commission and the Wellcome Trust for their support for this event. Nuffield Council for making time. I mean, the two colleagues have come up for meetings, but they agreed to be part of this. And I know Amanda is very busy teaching, so thank you.
Thank you.
Amanda, Steve and Craig from the AV team, thank you so much. Helps a lot to have high quality recordings, which we can then put up the WHO database for colleagues from the UN and governments to access these recordings as and when they wish. So thank you everybody for making time, for being here, and see you again. Thank you.